Good. So this patient's coming in for evaluation of a lesion that's been growing in front of her ear here. You can sort of see that it's quite inflamed. I'm working with Dr. John today. So what do you think this looks like?
Looks like an epidermal cyst.
Yeah, it looks like an inflamed epidermal cyst. What I would tell you, so working in the clinic today, this is the equipment you sometimes deal with. You can see these are just terrible tweezers. So anyway, what we're going to be doing here is we're going to see if we can freeze this. Now this is an inflamed field, so anesthetic is a little bit compromised here. So we're going to see if we can just inject over top of the lesion, and then sort of see if we can open that up and get that to drain for us. So we're going to use lidocaine. Do you remember what class of drug that is, Dr. John?
It's like epinephrine base.
So it's slightly different. So this is an aminoamide class. So it's also an antiarrhythmic.
Catecholamine base.
Sorry.
Blocks the sodium channels.
Yeah, that's exactly right. So it's a type 1B antiarrhythmic that blocks the sodium channels. So say that's distending. That's going to be uncomfortable for her. So do you remember what Langer's lines are, Dr. John?
Basically, they run in the skin, basically in the direction of the muscle fibers.
Yeah, the underlying muscle fibers. So we generally want to target those. I apologize for this. It's going to sting a bit. You okay?
Yeah.
You can see how that's sort of draining through here. Does that hurt when I do that?
No.
So this is our number 11 blade. So that's just all you can see. That's sort of firm. There's some keratin in there. And the purulent material, all the purulent material is just dead cells. Is that hurting a lot?
No.
This is always the balance. You can do large circumferential blocks here, but the freezing is quite uncomfortable. So while we want to maximize her comfort for sure, we also don't want to cause distress if we can avoid it. So there's the balance to be had. You certainly, she felt that a bit more than I would like when we sort of incised it, but I wouldn't want to do a large block. That's quite uncomfortable for her either, so we're sort of caught with that. So once we drain that out, so you can see it's sort of evacuated, so then we want to eat of this cyst.
It's already ruptured.
The capsule is ruptured, but it's adhering to the sides. Could I get it out right now? Because yeah, that's the problem. So it's like a balloon. A balloon that's not full of air is pretty strong, the membrane, but as soon as you blow it up, it becomes quite thin. That's what this is like. So people who do these procedures will realize that this is not going to go away unless we take the membrane out, but you can't take it out right now. So we're going to have to let that heal. And then at some point, you're tolerating that fine?
Yes.
So this small area, this essentially is going to function like a curette. We won't do much more damage there because there's not a lot of loculations that are there. And that much you have to be careful with too, again, depending on how good your freezing is, because we don't want to just cause her pain unduly. And so what bacteria likely causes this to get inflamed, that's assuming it's infected? What type of classes are we looking at here?
Gram-positive, like staph.
Yeah, gram-positive. What's that gram staining based on? Do you remember?